Hello everyone, welcome to my session. Now today we are going to talk about acute diarrhea. So that is the topic today, acute diarrhea. Okay, that is in pediatrics. I am Dr. Waheed Hussain and today I'll be teaching you about acute diarrhea in children. Now coming to first, we'll learn a little about IAP definition. Okay, in IAP definition, diarrhea is defined as passage of more than or equal to 3 loose or watery stools in how much time? In a 24-hour period. In a 24-hour period. Okay. Now what is the meaning of a loose stool? A loose stool is a one that would take, a loose stool is one that would take the shape of the container it's poured in. Shape of the container it's poured in. Okay, so you have understood the meaning of what is acute diarrhea. Okay, so diarrhea is defined as passage of more than equal to 3 loose stools or watery stools in a 24-hour period. A loose stool being one that would take the shape of the container. Now what is acute watery diarrhea? Acute watery diarrhea. Okay, acute watery diarrhea refers to the diarrhea which begins acutely, okay, lasts for less than 14 days with passage of frequent loose or watery stools, okay, without visible blood. There may or may not be vomiting associated with it. There may or may not be fever associated with it. Okay, and sometimes, very likely, it's going to end up with dehydration, and along with dehydration comes dyselectrolytemia. Okay, so all this it may result in. All right, so this is about acute watery diarrhea. Now what is dysentery? What is dysentery? Dysentery is of infectious cause. First thing you need to know, it's an infectious cause. It begins acutely and has visible blood or mucus. Mucus or blood is visible. Okay, there may be association of fever and there may be association of tenesmus. Okay. Now in clinical features, you may see that the child is having a rapid weight loss. Okay, there may be anorexia, and the complications of dysentery may be like some organ damage like renal failure, or even sometimes encephalopathy may result, okay, as a complication of dysentery. Now what is persistent diarrhea, what is chronic diarrhea, we will learn in further videos. Okay, now I am not going to concentrate on those. Okay, so now let us go to the epidemiology. Okay, what is the epidemiology of this? Now the causes of death in acute diarrheal disease, what we need to know is dehydration. You need to know that acute watery diarrhea or acute diarrheal disease is one of the most common killers of children below 5 years of age. Okay, so and the most common reason for that is dehydration. Okay, and this may be a complication which is associated with dysentery. Sometimes the child may be malnourished because of that. Okay, and sometimes there may be serious infections associated like severe pneumonia. Okay, associated infections. So in all these things there may be a more severe outcome, what you need to know. So how do you do the diagnosis per se? Diagnosis per se, how do you make? Okay, the child will have a history of passing frequent loose or watery stools. Okay, there may or may not be, very sorry, there may or may not be vomiting, there may or may not be fever, there may or may not be pain abdomen. Okay, there may or may not be blood in the stools. This is the history. Clinical triad of rotaviral diarrhea, I will tell you at this point. Okay, rotaviral diarrhea. Clinical triad. How do you clinically say that this is a rotaviral diarrhea? There will be fever, there will be profuse watery stools. There will be profuse watery stools. Okay, and along with profuse watery stools, the last thing which will be is vomiting. So we have fever, vomiting and profuse watery stools. This is rotaviral triad, and therefore all this will cause increased tendency for dehydration. Okay, there is an increased tendency for dehydration. Now, when does the symptoms of diarrhea start per se? The symptoms of diarrhea will start quite late, not so as soon as there is a 1% body weight loss of water loss, there won't be symptom of diarrhea. At least loss of 5% should be there. So 5% body weight fluid loss will cause symptoms of diarrhea, symptoms of dehydration, sorry, symptoms of dehydration. Okay, now when this 5% reaches 10% body weight fluid loss, there will be hypovolemic shock which is setting in. Hypovolemic shock, and this will culminate in a lot of events. A cascade of events will start which may result in death if there is no appropriate intervention. If no appropriate intervention. Okay, so this you need to know. Apart from this, what we need to know in the clinical aspects is dysentery cases. One thing you need to do, dysentery cases, especially in less than 1 year age group, you need to rule out intussusception. Because when we were in UG and we were studying for even NEET PG or basics of pediatric surgery, what you need to know, intussusception presents with something called as red currant jelly stools. Okay, so it's a differential diagnosis of dysentery, so you need to rule out. Then one may questions, like you may question to me, what is the indication, when do you do a stool culture or a microbiological evaluation in a case of acute diarrhea? So next I am going to teach you a little bit about indications of microbiological evaluation in children with acute diarrhea. So when do you go for any evaluation of microbiological evaluation in a case of acute diarrhea? Okay, so what do you do? Number 1, if age is less than 3 months. Number 2, if the patient is in shock or septic in appearance, septic appearance of patient means very toxic appearance. Okay, more than 10 liquid stools per day, more than 10 liquid stools per day with high fever, okay, plus or minus blood or mucus in stools. but there is high fever and a lot of stools, like more than 10 per day, definitely you can do a microbiological evaluation. Then recent history of travel, okay. Immunocompromised children, okay, immunocompromised children, okay. If there is an outbreak, many people presenting, many children presenting at once, okay, or it is a chronic diarrhea. In this cases we will go ahead for microbiological evaluation, but as I have told, in acute diarrhea we can ignore the last one here, okay. One second, sorry for that. Yeah, so chronic diarrhea also you need to do. Now what are the indications for, one second, this was about the microbiological evaluation. Now what are the indications for complete stool examination? Like just like you have a complete urine examination, there is something called as complete stool examination, in which they will tell about the every details, minute details about the what can I say, about all the parameters of the stool, okay. So pH, for example, or reducing substances and all these things. So for indications for complete stool examination, any infant who are having fever along with diarrhea, okay, sorry very much, any infants with fever, then suspected amoebiasis, you are suspecting amoebiasis, so you will look for the any findings of amoebiasis or Entamoeba histolytica in the stool. Then any extra intestinal infection is there, extra intestinal infection, okay. If there is a persistent symptoms of colitis, like the tenesmus and all that, okay, so colitis, evidence of colitis persistent, and if the child is malnourished, malnutrition, in a setting of malnutrition you will go for complete stool examination, okay. And then yeah, so we have spoken about the indications for microbiological evaluation in acute diarrhea and indications for complete stool examination. Next I will be adding a note on indications, this is important, indications for admission, because everyone keeps asking, the parents as well as the postgraduates, when should we admit a case of acute diarrhea, okay. So if there is, what are the indications of admission in acute diarrhea, okay. So when do we admit, everyone's having that question. So number one, obviously if a patient is having shock, very easy, if the patient is in dehydration, which is more than 9% of the body weight, okay. If there are any neurological signs, what are the neurological signs? Lethargy and seizures, means there is dyselectrolytemia, for example. And if there is intractable vomitings, or bilious vomiting, any of these two, you should admit the child, okay. If there is failure of OP basis treatment, you have given, but child still comes back to you saying that the mother still comes back to you telling that the child's loose stools are still going on and the child is becoming dull or sick, or the stool frequency is increasing, not decreasing, Okay, vomitings are increasing, child is becoming more dull, it's not able to accept orally, all right, and all this failure of oral treatment, okay, OP basis treatment. And then you are suspecting the cause of the diarrhea to be a surgical illness, a surgical disease. Okay, if you are suspecting a surgical disease, better to go for admission. Okay, and last but not the least, which is very quite important, the caregivers could be anyone. Caregivers, mother or father or the grandparents, not appropriate, not appropriate. In what terms? In what terms are they not appropriate? To give care at home. Okay, and this OP basis, it is ORS based therapy. Okay, so at home they are not able to give the appropriate care. So all these are the indications of admission. Okay, and clinically, are there any ways to differentiate between viral diarrhea and bacterial diarrhea? There are. Okay, let us discuss this. Viral is usually watery diarrhea, whereas bacterial is usually bloody, that is dysentery. Here there will be low grade fever. Here usually in bacterial it will be a high grade fever. Okay, high grade fever. Then sometimes it may be high, sometimes high grade in viral diarrhea. Okay, one thing you need to know, this is a high volume stool. In bacterial, it is usually a low volume stool, which is a dysentery. Low volume stool. Okay, the more predominant symptoms along with this is vomiting. Okay, vomiting is predominant in viral diarrhea, whereas in bacterial diarrhea, more predominant is abdominal pain. Abdominal pain. All right. Now, which system gets involved? Complications wise, which system gets involved first? Viral means what? They are more viral picture, viral. We think about respiratory symptoms. So they may have respiratory complications. So they may develop something like URTI, LRTI. Okay, respiratory complications are more. Whereas with something like, let's say, a bacterial dysentery and all, what do you expect? You expect that something more severe happens. So there are neurological complications in this. Okay, all right, this is about the what you can discuss a little about viral and bacterial. Okay, so till now what all have we discussed in this today's discussion? We have discussed about acute diarrhea, IAP definition of diarrhea. We have discussed a little what is acute diarrhea. We have discussed about dysentery a bit, what is the definition and problems. Epidemiology we discussed a bit. The diagnosis, how do we get a history, okay, and clinical triad of rotaviral diarrhea. We discussed about the indications of microbiological evaluation, indications of complete stool examinations, indications for admission in acute diarrhea, and viral bacterial differences. Now we can now rest and go for the something interesting. We will go for management of acute diarrhea. This is something simple because you have been learning this from the UG days itself. Now, what are the principles? First, I would like to tell principles. I'm not going to write down everything. You need to know certain principles. What are the principles? You need to have a general assessment of the child first. Okay. Then you should do special assessment of hydration status. Assessment of hydration status. Okay. Then you should look for any abnormalities of acid base balance or electrolyte and correct them. Correction of electrolyte or acid base disturbances. Okay, then you should see that proper feeding is continuing. There is a continuation of proper feeding. Okay, proper feeding to provide normal nutritional support. Normal nutritional support. Okay, then you need to look for definitely that the child is getting zinc supplementation. These are the general principles which I am telling. Zinc supplementation. If there is associated treatment of associated dysentery, okay, then nutritional rehabilitation of the child should be done if required. Okay, rehabilitation. Okay, and health education for prevention of diarrhea. Health education of whom? Parents. Okay, now this is about the general principles. Now going next, this is something which is very simple, which you know. I will basically write a table. This is sign. This is a feature of first. Okay, fine. I'll just write it. So there are three types of signs which can come in a child of diarrhea. In first one we will see the general condition of the child. Okay, general condition of the child. In general condition, if he is well or alert, we'll give 0 points. This is 0, this is 1, this is 2. Okay, if the child is restless, if the child is irritable, okay, we will give 0.1. And if the child is lethargic or unconscious, you will give 2 scores, score 2. Okay, next, after general condition, we have eyes. Eyes, if they are normal, 0, slightly sunken, 1, very sunken, 2. Okay, number 3, thirst. Number 3, thirst. In thirst, drinks normally, okay, and not thirsty is 0 points. Drinks eagerly and is thirsty is now 1 point, and drinks poorly or not able to drink is 2 points. Okay, next, after thirst is skin pinch. You will do skin pinch over the abdomen. If it goes back quickly, it is 0 points. Goes back slowly is 1 point. Goes back very slowly is 2 points. Okay, next, you should look for mucous membranes. Okay, mucous membranes are normal, that is 0 points. Sticky is 1 point, dry is 2 points. Then you come to the last aspect, that is tears. Normal 0 points, decreased 1 point, absent 3 points. Now how do you divide this? 0 to 1 we are calling it no dehydration. Okay, 2 to 4 you are saying as some dehydration, and more than equal to 5 is severe dehydration. Okay, more than equal to 5 is severe dehydration. All right. Now this is not what I'm talking in terms of our IMNCI. Okay, this is the British one. In our IMNCI it says to this entire thing they call it as no dehydration. Okay, there's no scoring here. This no dehydration child should be this. If any of the number 1 point there are 2 or more signs of this column, they call it as some dehydration, and 2 or more signs of this column they call it as severe dehydration. Okay, so that is about this. And if there is no dehydration, what do we start? We start plan A. If there is some dehydration, we start plan B, and in severe dehydration we start plan C. Okay. Before we get into all of that, first I will like to talk about what is oral rehydration therapy. Oral rehydration therapy. Okay. Now we know what is the principle of oral rehydration therapy, right? It's a coupled active transport of glucose and sodium in small bowel. This results in passive absorption of water. Passive absorption of water and other electrolytes also. What is that phenomenon by which it does that? That is called solvent drag. Solvent drag. Okay, that is what is happening. Now what does oral rehydration therapy include? Does it include only ORS? No. So it has ORS definitely, but even a solution which is made of water plus sugar, salt, if prepared correctly, that is okay, that is important. Sometimes some food based solutions also can be oral rehydration therapy with appropriate salt concentration. Okay, for example, like lentil soup, rice, kanji, buttermilk. Okay, all these are the food based solutions. And then plain water given along with continuous feeding. Continued feeding is also a part of ORT. Now what is the ORS which we are using now? Okay, what are the ORS which we are using now? We are using something called as low osmolality ORS. Now to know about it, in grams per liter and millimoles per liter. Okay, grams per liter may will have composition wise sodium chloride 2.6, anhydrous glucose 13.5, potassium chloride 1.5, okay, and trisodium citrate trisodium citrate dihydrate, this is 2.9. If you come to millimoles per liter, which is more important for you to remember, sodium 75, okay, sodium 75, chloride 65, anhydrous glucose again 75, potassium 20 and citrate 10. This total comes to 245 millimoles per liter, which is low osmolarity ORS. Okay. Now ORS, this ORS is a universal solution. What you need to know is it is a universal solution. It's a universal solution for treatment and prevention of dehydration for all causes of diarrhea in all age groups. All causes of diarrhea for prevention and treatment. Okay, all causes of diarrhea and all age groups. This you need to know. All age groups it can be used. Okay. Now coming to a management of no dehydration. How do you manage a no dehydration child? Okay. Now this is successfully carried out at home. What you need to know is a home based management by the mother or the caretaker. You give more fluids than normal. More fluids than normal. You continue the feeding of the child. Review to your pediatrician or the doctor which you have visited in 2 days. Okay. When do we review earlier? Earlier we review when there are danger signs. What are the danger signs? Danger signs is if the child is getting thirsty, okay, if the child is getting irritable or restless, okay, and if there is a fever, okay, if there is a high purge rate, okay, if there is repeated vomiting, if the child develops blood in stool, if the child gets lethargic, okay, and eating and drinking becomes poorly, okay. For all these indications are the danger signs. You have to review with less than 2 days, or else you have to review in 2 days. This is the management of no dehydration. Now what is the age wise classification of supplement, like supplementing more fluids than normal? So age we will write here, and we will write the after each loose stool how much to give fluid after each loose stool, here this side. Okay. So if it's less than 6 months, we will give 50 ml. This is 1/4 of a glass. Okay. From 7 months, sorry, yes, 1/4 of a glass. From 6 months till 24 months, okay, we will be giving 50 ml to 100 ml, and this is nothing but 1/4 to half of a glass. Okay. Now if the child is more than 24 months but less than 5 years, less than or equal to 5 years, we will give 100 to 200 ml extra, that is half to 1 glass. After each loose stool we are talking this is, and the child is more than 5 years, we will giving as much as the child can take. Okay. So this is about the management of no dehydration. Now next we will go to management of some dehydration. Management of some dehydration. So in management of some dehydration, first we have to correct the dehydration. So in this we will take 75 ml per kg of ORS, which is to be given over 4 hours. If the child wants more, more can be given. Breastfeeding should be continued, and then you should reassess again after 4 hours. If the child is still dehydrated, again repeat the plan B. If it's rehydrated, then you should treat as no dehydration. Okay? If oral rehydration therapy is not successful, you can go for IV fluids, that is IV fluid at 75 ml per kg. Okay? And if at any point you find features suggesting severe dehydration, you should go ahead with plan C. All right, done. This is about the some dehydration, more or less. Okay, this is like the summary, you can say, of the management. Then I'll go for management of severe dehydration. Management of severe dehydration. Now in this, ringer lactate is prevent over NS. Okay, you should give 100 ml per kg totally. Okay, 100 ml per kg is given totally. This, you know, again there is a table, less than 1 year, more than 1 year. What is the volume to be given? In less than 1 year, you will give 30 ml per kg over 1 hour, and rest of it, that is 70 ml per kg, you will give in 5 hours. Whereas if it's more than 1 year, 30 ml per kg you will give over half an hour, and the 70 ml per kg you will give over 2.5 hours. So total here is 3 hours, total here is 6 hours. At the end of which you should again assess for improvement every 1 to 2 hours. If the baby is not improving, you can give the infusion rapidly. Give infusion rapidly. Okay, as soon as a child is able to drink, you will start ORS. As soon as a child is well enough to drink, start ORS at 5 ml per kg per hour. Okay, understood? This is about management of severe dehydration, more or less. Okay, now what about the one small point which I want to add is rehydration in SAM. Rehydration in SAM. Rehydration in SAM, we use something called as Resomol, that is rehydration solution in malnutrition. Malnutrition. Okay, in malnutrition, what is the rehydration solution we use? Resomol. So in Resomol, there is slow rehydration is done, more vigorous monitoring is done in a malnourished child, and feeding is initiated as soon as possible. So how do we prepare this Resomol? You will take 2 liters of water, you will take 1 packet ORS of 1 liter packet. Okay, you add 50 grams of sugar, and you will add 40 ml of electrolyte mineral solution. Okay, when you combine all this, you will get a Resomol. All right. Now then we need to talk even about zinc supplementation. The zinc supplementation for less than 6 months, we will give 10 mg per day, and for more than equal to 6 months, we will give 20 mg per day. Total period to be given is 14 days. What does zinc do? Zinc decreases the severity of the diarrhea. Zinc will decrease the duration of diarrhea, and zinc will decrease the risk of persistent diarrhea. Okay, so this is about zinc. Okay, and then we'll add another note on antimicrobial agents. Antimicrobial agents. Now what about antimicrobial agents in acute diarrhea? When do we give it? When we are suspecting the child to be having a dysentery, or we are suspecting the child to be having acute cholera. In these both, we will give the antibiotics. So what about acute cholera? In acute cholera, we will give doxycycline, which is the first choice. Doxycycline is the first choice. It is a single dose at 6 mg per kg oral. First line, this is 6 mg per kg oral. Okay, single dose. Then second line is ciprofloxacin. at 15 mg per kg. Okay, this is about acute cholera. What about dysentery? In dysentery, our first line is ciprofloxacin. The first line is ciprofloxacin. This is 15 mg per kg per day in 2 divided doses orally for 3 days. And second line is ceftriaxone, which is 50 to 100 mg per kg per day, okay, for 3 to 5 days. Okay, so this is about the dysentery. This is bacillary dysentery. Well, what about bacillary dysentery? Yeah, so that was about bacillary dysentery. What about amoebic dysentery? Amoebic dysentery. In amoebic dysentery, we will give metronidazole. How much? We will give 30 mg per kg per day in 3 divided doses. Okay, 3 divided doses, 30 mg per kg per day, we will give for 5 to 10 days. Okay, okay now. So this was about the antimicrobial agents which we will mention, and then coming next to the last part. I'll be talking about complications. Little about complications. Okay, little about each complication, you can say. Overall, few complications, important ones we'll discuss. The number 1 is electrolyte imbalance. Electrolyte imbalance. All right. So electrolyte imbalance में we'll be doing, first one is hypernatremia. Hypernatremia. So hypernatremia, when does it happen? When parents give canned fruit juices, carbonated cold drinks, okay, or incorrectly prepared sugar salt solutions, we may result in hypernatremia. That is, this may be sodium more than 150. Sodium more than 150 milliequivalents per liter. Now the child may have convulsions, okay, and they have increased thirst. What is the treatment? You give low osmolality ORS, and if the child is very sick, you may go for RL. Okay, if sick, go for RL. Coming next to hyponatremia. In hyponatremia, this happens when the child is taking huge amounts of water, large amounts of water, but there are no salts in it. So they can, when there is dehydration and just keep giving water, the child may result in hyponatremia. In this, sodium will be less than 130 milliequivalents per liter. This is associated again with convulsions, but along with that will be lethargy. Okay. During treatment, again you have to give low osmolality ORS, and if sick, you go for RL. Okay. Coming next to is hypokalemia. Hypokalemia is when potassium is less than 3 milliequivalents per liter. This will present with muscle weakness, paralytic ileus. Okay, paralytic ileus. There may be renal impairment, and of course there will be cardiac arrhythmias. Okay. Now severe hypokalemia in a malnourished patient, it may result in an acute onset flaccid paralysis, and this may lead to neck flop. May again progress to quadriparesis, and then it may progress to a respiratory paralysis. So dealing with hypokalemia is quite important, the treatment of which is again a low osmolarity ORS. And if the child is not so sick, you may supplement him with a banana. Banana is a very rich source of potassium. Now, oral potassium supplementation, in whom to give? Oral potassium supplementation is recommended in malnourished children. Okay, in malnourished you may give oral potassium supplementation. Okay, so this was about the electrolyte disturbances. Now coming next to hypoglycemia. Second, hypoglycemia. Hypoglycemia, how do you reduce the risk? If you give continued feeding, this will minimize the risk of hypoglycemia. And if the child is less than 2 months, or if the child is sick, you can give 10 ml per kg of express breast milk or animal milk, which is with added sugar. Added sugar, that is important. Added sugar, less than 2 months. Okay, infants, if sick, and if sick. If both are not available, you may give, that is animal mother's milk is not available, animal milk is not available, 10 ml per kg sugar water also you can give to the child. Okay, sugar water you can give to the child. Okay, this is about normal child. If sick, obviously you go for the IV correction of the hypoglycemia. Okay, then coming to third one, metabolic acidosis. Metabolic acidosis, this is because of large amounts of bicarbonate which is lost in stool. So if you give ORS solution, this will replenish the base deficit. Okay, ORS will replenish the base deficit. But in severe dehydration and there is no renal compensation, the base deficit will develop. So in that cases, when there is severe cases, you will give 2 to 3 milliequivalents per kg of sodium bicarbonate. Okay, 2 to 3 milliequivalents per kg of sodium bicarbonate based on the sickness, orally or IV you can give. Okay, then coming next to acute renal failure. Okay, acute renal failure. In acute renal failure, this is most likely going to be which type? Prerenal type. Okay, because of the hypovolemia, prerenal type may be there, which is due to decreased renal blood flow. Immediate replacement of fluids is helpful in this. Okay, and the last complication which I want to discuss with you is HUS, that is hemolytic uremic syndrome. This is due to which one? Shigella dysenteriae, Shigella dysenteriae or enteroinvasive E. coli. Okay, this is due to a nephrotoxin which develops the hemolytic uremic syndrome. Then there is intravascular hemolysis, and there is acute renal failure. Okay, this is a very severe complication which can happen in an acute diarrhea. So this was about the complications. Okay, so roughly again, if I start from here, from the management part, what you need to know is management wise you need to know, first you need to know the principles of management what we have given. Then we divided the no dehydration, some dehydration and severe dehydration signs and criteria. Okay, plan A, plan B, plan C. And then I told you a little about the oral rehydration therapy, composition of the ORS. Okay, what is the management of no dehydration, that is plan A. Then the management of some dehydration, that is plan B. And what is the management of severe dehydration, that is plan C. And then a little bit I told about the rehydration in SAM and zinc supplementation. Then a little bit I added a comment on the cholera and the dysentery, bacillary as well as amoebic management, that is antimicrobial management in acute diarrhea. And then we discussed a little bit about the complications. Okay, so this will suffice for you to know about what is the okay, so what are the basics of acute diarrhea, which is to be known by a postgraduate who is practicing clinically as well as for his theory. Okay, so once again, thank you very much for listening to my class, which could get a little bit tedious because this is a postgraduate oriented teaching. Okay, and I want to complete let the person who is listening to this video to get a deep grasp of the subject. Okay, and the sources of the, again like I told, IP specialty series of gastroenterology along with diarrhea, and I even used our Springer textbook of Gastroenterology. Gastroenterology. Okay, so in the coming videos I'll be talking about persistent diarrhea separately in a separate video and a chronic diarrhea in a separate video. Okay, so until then, please give me permission to be absent. Okay, thank you so much. Good night.